Dr. Jayasri, Kanthalu, Narayanamooorthy. You can start.
Good afternoon to all. My presentation is on neuro-ophthalmic manifestation of tuberous sclerosis, a case series. Neuro-oculocutaneous syndromes are a group of disorders characterized by multi-system involvement. One among is tuberous sclerosis affecting 1 in 6,000 population. It is autosomal dominant inheritance. While retinal findings are common in tuberous sclerosis complex and important in diagnosis, it has many neuro-ophthalmic manifestations. These manifestations are important to recognize because they can be a sign of life-threatening disease or may have a significant impact on quality of life. In this case series, we encountered 3 cases of tuberous sclerosis with neuro-ophthalmic manifestation. It is a retrospective analysis of 3 patients who presented in the year 2023. Let us start with case description. Case 1, 13-year-old boy came with complaints of defective vision in both eyes since 1 week. Past history of 1 episodes of neonatal seizure was present. Sibling history of surgical excision of subependymal giant cell astrocytoma tumor removal was done. On general examination, patient had adenoma sebaceum, Sagarin patch, subungual fibroma, as-leaf macule. Ocular examination, best corrected visual acuity, bisenal optotype, right eye 1/60, left eye 6/9 partial, pupil right eye showed RAPD, color vision both eye defective, visual fields right eye not possible, left eye showed depressed fields. Slit lamp examination, iris shows as-leaf macule. Fundus examination, bilateral papilledema, disc edema was noticed. So we ordered neuroimaging. T1 weighted axial and sagittal section showing large expansile lesion in left side of foramen of Monroe with obstructive hydrocephalus suggestive of subependymal giant cell astrocytoma. So we refer the patient to neurosurgeon and underwent craniotomy and surgical removal of tumor was done. Histopathological examination confirmed the same diagnosis. Case 2, 9-year-old boy came with complaints of defective vision 3.5 months. Surgical history of excision of SEGA was done 3 months back. Sibling history of features of tuberous sclerosis was present. On general examination, patient had adenoma sebaceum. Ocular examination, best corrected visual acuity, right eye 6/24, left eye 4/60. Color vision both eye defective, visual fields both eye unreliable. Fundus examination showed both eye optic atrophy. So we reassured the patient, advised to continue the neurosurgeon treatment, and last follow-up after 6 months, the patient vision has been improved, right eye 6/12 partial, left eye 6/24. Case 3, a 27-year-old boy came with complaints of both eye defective vision since 1 week. On examination, adenoma sebaceum over the face since 15 years. On examination, best corrected visual acuity, both eye were 6/18, color vision both eye defective, visual fields both eye were normal. And fundus examination shows bilateral disc edema with mid-peripheral hemorrhages and cotton wool spots. So we ordered neuroimaging, which showed T1 weighted coronal and sagittal section showed SEGA in left side of the foramen of Monroe with obstructive hydrocephalus. So patient was referred to neurosurgeon and underwent craniotomy and surgical removal of tumor. So coming to the discussion part, tuberous sclerosis is a complex multi-system disorders with well-described genetic causes. History. In 1880, von Recklinghausen described TSC as Brown-Willy-Brinkel disease. It manifests as benign hematomas of heart, kidney, brain, skin and eyes. In 1908, Heinrich Vogt described it as Vogt's triad. In 1911, Serlac described Vogt's triad at epiloia, epilepsy, low intelligence, adenoma sebaceum. In 1932, Van der Heever described it as retinal hematomas or phakomatosis. So ophthalmic manifestations are iris as-leaf macule, iris hematoma, retinal astrocytic hematoma, exudative RD, optic nerve head hematoma, papilledema. Others are craniopalacies, visual field defects and cortical visual impairment. So the diagnostic criteria for TSC by International TS Consensus Group, the genetic diagnosis is made on the presence of pathogenic mutation to either the TSC1 gene encoding hamartin or TSC2 gene encoding tuberin. So they inhibit the mammalian target of rapamycin pathway, which results in unregulated cell growth in different germ layers causing hematoma. So the clinical diagnosis is made on the presence of major features and minor features. The criteria for the definitive diagnosis are 2 major features or 1 major feature with 2 or more minor features. The possible diagnosis are either the 1 major features or 2 minor features. So in our case series, the clinical diagnosis was made and defective vision was the chief complaints, which is rarely reported. The incidence of SEGA is 5 to 14% and tend to occur in first and second decade of life. In all cases, obstructive hydrocephalus was provoked by large SEGA in lateral ventricles, which results in increased ICT and papilledema. Although SEGA are slow growth tumors, they are responsible for about 25% of mortalities associated with TSC. So to conclude, vision loss in tuberculosis can occur due to secondary optic neuropathy. Neuro-ophthalmic manifestations, though not included in diagnostic criteria, have significant impact on visual function and indicate serious underlying neurological disease requiring urgent workup and treatment. So multidisciplinary team approach is crucial element in improving patient outcome. Thank you.
How many cases had this
3 cases.
optic neuropathies?
3 cases we are.
3 cases. These are usually called as phecoma. It's a group,
Yes.
phecomatosis is a group
Yes.
of conditions where there's a tuber formation in CNS other parts. And the group of the conditions which you have in this thing are SLE, your this tuberous sclerosis, ataxia telangiectasia,
Yes, sir.
neurofibromatosis, arteriovenous aneurysms of brain, the spinal cord. The retinal hematomas are one of the commonest manifestations of tuberculosis.
Tuberculosis.
The hematoma you get to other parts. Besides, they have got a raised intracranial pressure.
Yes.
And optic neuropathy. It's a very good presentation. Very good presentation. Thank you very much.
Thank you, sir.
It was a very good presentation.
Thank you.
Just want to know that did you get the genetic testing done for any of these patients?
No, madam. Only the clinical diagnosis based on the ophthalmological and radiological findings only we have to make.
Was there any family history?
Yeah, 2 patients, the same family, madam. Sibling history is there. And among the 2 patients, one patient, 1 month post-op, he was expired because of that some surgical related complications, or he had hemiparesis and seizures and expired.
Anybody else in the family other than the?
No, no.
The other condition where you get this choroidal and the retinal hematomas are neurofibromatosis.
Yes, sir.
That you have to keep in mind.
Yes.
And in the neurofibromatosis, you get angioid streaks, you get a glioma of the optic nerve, you get iris changes in neurofibromatosis.
Least
But yes, yes. Good.
Okay. Thank you very much.
Thank you.